Hello and welcome, and thank you for attending this ICD-11 webinar. My name is Claire Orkim-Hasty and I'll be your moderator for the panel section of this discussion. What we'd really like you to do now is to add any questions you might have to the Q&A section, and then I can read that out to our panel and we can get a really good discussion going. I'd like to introduce our panel today. Today we have with us Shahid Khan from Imperial College London. We have Hassan Malik from Aintree Hospital in Liverpool. We have John Bridgewater from UCL Cancer Institute. We have Robert Jakob from the WHO. And we have Andrew Murphy from the National Disease Registration Service. And we also have with us Helen Morement from the AMMF. So please go ahead and add your questions and we'll get the discussion going. Okay, so we can start off with some questions here. So we have for John, what are the clinical implications of the molecular determination of CCA subtype, John?
Thank you. Well, personally, I think they're really, really important. As I mentioned in my talk briefly, about half of the intrahepatic cholangiocarcinomas have what we call an actionable alteration, a target. Sadly, half of them don't. But if you do, that means you can have a targeted therapy. For instance, the recently approved pemigatinib drug. This is a tablet. Compared to chemotherapy, it has virtually no side effects and works really well. It also tells us, we also know that the group who are able to receive pemigatinib generally do a bit better anyway. So it gives us both information about how well people do and how and also you know, it's great to be able to give these people a non-toxic treatment that is effective. That's really, really important. Now, pemigatinib is just one of the several targets we have in intrahepatic cholangiocarcinoma. There are fewer targets in the other types, in the extrahepatic, both distal and hilar. Nevertheless, there are some targets, and we need, you know, we must keep looking for these, keep offering these to our patients, and the principle of that all cholangiocarcinomas must get a molecular profile to inform us about this. That's a step change in the way in which we manage these and other cancers, and you know, that process is gradually working its way through the system. It's not perfect yet, but it's getting there, and you know, most of us oncologists are relishing the prospect of being able to offer non-toxic treatment to our patients. So the molecular bit is huge. It's really important.
Fantastic. Thank you, John. And Shahid, sort of expanding on from that, how could that sort of better differentiation, getting that molecular subtyping, how could that improve the clinical management of patients, do you think?
Well, I mean, historically, if we look at cancer trials before the sort of era of personalized medicine came in, you know, a long time ago, we'd give a new chemotherapy drug would come out, you'd give it to people with cancer, and 10-20% might respond and the others wouldn't respond, and didn't really know why. But now we know that cancers, particularly liver cancers and cholangiocarcinomas, are quite heterogeneous tumors. They have different driver mutations, and if as a patient you have a particular driver mutation that is specifically targeted by the therapy, then you're more likely to respond. So the idea is that if we can profile people's tumors and give a specific therapy targeted to their driver mutations, then they're more likely to respond and have improved survival and have benefit, rather than a sort of blanket systemic treatment for all patients with the same tumours, because we know these tumours are quite heterogeneous. So again, it's about tailored treatment for the patient.
Fantastic, thank you. And Hassan, do you think this also has an impact on surgical treatment options as well?
Well, I think you have to it's a chicken and egg situation. I mean, we know from the data that AMMF have worked really hard on, and Shahid, that about half the patients diagnosed over a long period of time in England had no treatment whatsoever. And it's important that all patients, and this is really focusing on the clinical aspects rather than coding, all patients are referred to the local centre of expertise for an opinion. Certainly some of the intrahepatic tumours are misdiagnosed as a CUP or cancer of unknown primary, and treated along that pathway rather than diagnosed as perhaps a multifocal intrahepatic cholangiocarcinoma, where the treatment would be fundamentally different. And again, getting biopsies is crucial. But as a surgeon, I mean, about 20% of the patients who come across our tumour board will be looking at a resection, and we will, we will design that surgery for that particular case, whether it be a left-sided or a right-sided liver resection, or a central resection, or resection of the bile duct with the liver. So every case is fundamentally different. So we as surgeons in our tertiary centre do that. But what I'm always amazed at is what I see after we've done our bit, the coding side of things. I've looked at HES, which is the hospital episode statistics data, and I'm shocked to see an operation which has got a kind of fingerprint for a cholangiocarcinoma surgery, which includes resection of the liver and the bile duct and a biliary reconstruction. That is a unique operation for a hilar cholangiocarcinoma, but the diagnosis is colorectal liver metastases. So, not even talking about coding it, whether it be intrahepatic or a perihilar, but actually getting the wrong cancer, it just amazes me. So it is crucial, and I think the patients do deserve getting the coding right, and I think that's the message I want to pass on today.
Fantastic. Thanks, Hassan. And Helen, I wonder if you could talk a little bit more on why this ICD-11 coding is so important to the CCA and patient advocacy community.
Thank you, and I'd just like to thank everybody who's contributed this morning to the presentations and also to this discussion, because it's absolutely vital that in the battle to get improved treatments and futures for cholangiocarcinoma patients. Well, lack of robust data is a problem that has plagued the cholangiocarcinoma arena for many, many years. And because of this lack of robust data, what we at AMMF see, which is increasing numbers of people getting diagnosed and younger people being diagnosed, is just really considered anecdote and opinion. And I've been told many times, without cold hard data, forget it. We now have our own data project, which was touched on by Hassan, I think, but also hugely importantly, in ICD-11, cholangiocarcinoma will be recorded or is coded in its 3 anatomical types: intrahepatic, perihilar, and extrahepatic or distal. To this point, in ICD-10 and its previous iterations, there was no code at all for perihilar. And if you speak to any expert on cholangiocarcinoma, they will tell you that this is the most commonly occurring kind. And in fact, Shahid illustrated that very well in one of his tables earlier. So the lack of data, because you can't record it properly, because there's no coding to enable the proper recording of cholangiocarcinoma, it gets miscoded, misrecorded. And so we don't have that robust data to support what we really should be doing for patients. And because, you know, the data is so skewed and it depends what you search for, it leads to a lack of interest. It leads to a lack of awareness, and therefore the neglect of a lot of patients who really should, or who really do deserve a lot better. So I'm really strongly of the opinion that if we can get this improved coding adopted as quickly as possible, so that the disease is recorded more accurately, that will, obviously it's not going to happen overnight, but that will lead to much more robust data to actually prove what we see is happening. And therefore we can move forward with asking for policies to be changed, asking for better pathways, asking for better even centers of expertise for these patients. And so, you know, coding is at the root of this, I think, and is going to be extremely helpful throughout the UK, throughout Europe, throughout the world, really.
Fantastic, thank you, Helen. And kind of moving on from that, Helen, I wonder if Robert, you could talk about how we could encourage uptake of ICD-11 for CCA globally.
Well, the encouraging is essentially a matter on how fast countries adopt the ICD-11, of course. The ICD-11 comes into effect from the 1st January 22, and countries will take some time until this will be in place. We know in other areas of ICD that some specialties have chosen to use two systems in parallel, the one that is mandated by the national law and one that delivers the detail, like for example in pain or in dermatology. And otherwise, we can just say that this may be an additional incentive to move as fast as possible by countries to the ICD-11 so that everybody can take advantage of this particular area, but also many other aspects that the classification comes with. Thank you.
Fantastic, thank you. I'd like to now just spend some time just to ask if there are any further questions that anyone would like to submit via that question and answer button. While we're kind of ready for those to come in, I'd like to thank the panel very much for your attendance and your discussion on this very important topic. To all participants, we will be sending out evaluation forms in the chat for your feedback. And we will be preparing a question and answer summary document from the 3 webinar sessions that will be circulated. And recordings will be available following the webinar, and these will be available in English, Thai and Spanish. And we'll also have an educational support meeting pack, which includes a slide deck and supporting materials for lunch and learn sessions that you could run in your own institutions. And there will be resources as well as materials on ICD-11 coding. Okay, I haven't seen any further questions come in.
Sorry, Claire, I think John has had his hand up once or twice, and I would also, I'll let John come in, but I also have a question I'd like to put to Andy if we have the time to do it. So I'll let John do his bit first.
Apologies, I can't see the hands up. Thank you.
Thanks very much. It was just, you know, I've asked him this question before, and I keep asking it him. But Hassan, how close do you think we are to centres of excellence in the UK? The UK has one of the most centralised health systems on the planet, and if it's going to happen, anywhere, it'll happen in the UK first. How close are we, do you think? Because we've seen the advantages that has generated for other cancers, esophagus, pancreas, and others. What's your view, please?
Okay. So apologies for the background noise. I'm in a busy train station. So not very close. I mean, we're halfway there, I think. I mean, all HPB cancer resections occur in defined centres, which are regional centres. I think the difficulty we have certainly around the more complex end of the surgery. So that would, in my book, be the perihilar tumours, where you're talking about a very high risk operation in a relatively rare type of cancer. You have centres which undertake a handful of those operations a year among 5-6 surgeons. Other centres, the surgery will be done by 1 or 2 individuals who have the expertise. We see that there is variability. Again, going back to the AMMF data, there is surgical variability around the country, but again, because of the difficulty with coding, we can't delve into that much further at this moment in time. We've had discussions from a commissioning point of view. I think we're halfway there. I think what will have to drive it is the clinical community, Cholangiocarcinoma UK, the patient charity. That's how we drive this forward. I think transplantation for cholangiocarcinoma may also support that agenda, because obviously transplantation can only be delivered in a handful of centres across the country. But it's important to have a balance, you know. So we need to take the best of what we have and ensure that we bring all centres up to that level if we can. But obviously, if there are outliers, then we need to have discussions with those places. It's also important to remember that the majority of patients are not surgical candidates. It's crucial that there is sufficient local expertise maintained to allow that care, or excellent care, to be delivered locally and close to that patient, whether that be endoscopic management of biliary obstruction, the oncological treatment options. Again, going back to the kind of oncology networks, you know, it's important that the oncology community are aware of all these advances in this rare cancer. Get that biopsy, get the sequencing, get the patients into clinical trials. You know, that I think is a strong message.
Thank you, Hassan. I think, Shahid, I think your hand's up.
Yeah, thanks. I had a question for Robert. Robert, thank you for joining us today. With the adoption of the new ICD coding, do you anticipate that different countries will take them up at varying times, and how does that work? Is it very variable, and how soon before everyone's using it?
Well, as you know, for example, the US have taken from 1993 until I think it was 2010 to adopt the ICD-10. So there are natural delays, and only recently one country switched from ICD-8 to ICD-10, actually 2 years ago. So the speed there is heterogeneous. With the experience with the move from ICD-9 to ICD-10, you can say usually within 5 years after adoption, things move in the countries. I don't know what the scheme is in countries of your interests, but we're closely working together, for example, with many of the European countries to facilitate the preparations that obviously need to be done before moving to a new coding scheme.
And thank you. And on a similar note, I was going to ask Andrew Murphy about. So Andrew, obviously you work in the UK, but what factors do you think determine national cancer registries in terms of when they take up changes in coding or how they incorporate them? Yes.
Thank you. Yeah, so we're very much guided from central NHS. So as soon as they adopt ICD-11, then we would also adopt ICD-11 at the same time. However, as you know, working with you very closely and with Helen over the last few years, we identified that there was this gap in the coding. So what we've done is we've actually made changes to the Cancer Outcome Services data set so that now actually the 3 specific areas for cholangiocarcinoma can now be recorded accurately within there, so that we can supplement the ICD-10 and the SNOMED CT coding that is also available.
And I just wonder, I mean, we don't know because none of us work in the US, but I just wonder in the US whether the insurance-based system plays a role or is irrelevant in terms of coding uptake. I mean, we'd be speculating, I know.
Yeah, I think we'd be speculating on that. I know from when I've been over there and spoken with registrars, they have a two-tier system with the within the hospitals of those that are led by the insurance companies and those that are not. But overall, they bring all the data together through CCA and they try and sort of standardize that data. So, but as Robert said, they took a very long time to move from ICD-09 to ICD-10. So to move to ICD-11, I'm not sure how long that will take them.
Thank
you. Claire, could I just come in with a question for Andy as well, if that's okay? Andy, you've heard from both Shahid and Hassan this morning how often cholangiocarcinoma is misdiagnosed. And I was just wondering that I know we've had many conversations and we've worked on the COSD, but is there anything that, you know, the clinical community can do or that can be done to encourage the better, more accurate coding and recording of cholangiocarcinoma at the sort of almost basic diagnostic level?
Yeah, so we not only receive the data through COSD, we also get all the pathology reports. So if it's clearly and accurately diagnosed and recorded within pathology, we can then actually make sure that we are defining that correctly within the cancer registry reports as well. And also over the last couple of years, we've been working very, very closely with all of the molecular centres around the country. So again, if there is molecular testing being done on patients with cholangiocarcinoma, then we're going to get that data coming in directly from the molecular laboratories, which again will allow us to be very, very accurate in the future with recording cholangiocarcinoma within cancer registries within the UK.
Well, that does sound quite hopeful, actually. So it's all what we really have to do is really, as again, as John raised this morning, really push for all cholangiocarcinoma patients to get molecular profiling, preferably at diagnosis and if all else fails during first-line treatment. And that way we will have more accurate numbers and more accurate data.
Absolutely.
Thank you.
Fantastic. So thank you to all for attending today, and I hope you have a great rest of your day.